All right, our next speaker is Dr. Brooke French, who will be giving a talk on computer-assisted planning and craniofacial surgery. So Dr. French did her undergraduate training at the University of Illinois. She then went to medical school at Southern Illinois University and stayed there for an integrated plastics residency. She then went to Canada to do a fellowship in pediatric craniofacial surgery at the Hospital for Sick Children at the University of Toronto. Luckily, we were able to recruit her here 10 years ago. She's a leader in cleft and craniofacial programs at Children's. She's the director of our cosmetic surgery program here at the University of Colorado. She's an outstanding clinician and a great teacher, and we really look forward to your talk this morning. Thank you, Dr. French. And you're still on mute. I don't know if you know.
Can you hear me now?
Yes.
Thank you. Thank you for the introduction, and thank you for the opportunity to present. I have no relevant disclosures. Today we are going to look at computer-assisted planning and understand the various types of technologies associated with it, review surgical applications largely related to craniofacial disorders and craniosynostosis and cleft in particular, and then measure the impact on the outcomes in craniofacial surgery and look at some future directions. So for purposes of today, we'll largely focus on craniosynostosis, and a brief overview is that the sutures of the skull should close in a predictable fashion. When they close prematurely, you achieve atypical head shapes. So in sagittal craniosynostosis, you get a scaphocephalic head shape, so it's elongated in the AP dimension. In unicorodal, you get an anterior plagiocephaly of the affected side, so it's a flattening of the forehead and a retrusion of the brow. In metopic, you get a trigonocephalic head shape, which is a triangularly shaped head. And in lambdoid, which is very rare, you get a posterior plagiocephaly with a mastoid bulge and an oblique hairline. These are usually of unknown genetic significance, but there's also the larger classifications of syndromic craniosynostosis. These are usually affiliated with a known genetic mutation and can involve multiple sutures and body systems. And the reason we treat these conditions is to normalize the skull and facial structures, as well as treat any craniocerebral disproportion that can lead to underprotection of the orbit or elevated ICP. And there are various ways to do this, as simple as a strip craniectomy, removing that fused suture and then passively molding their head with a helmet. Frontal orbital remodeling, removing the frontal bones and supraorbital bandeau. Total cranial vault remodeling, which is exactly like it looks like, to various degrees of various types of distraction osteogenesis to make the skull much larger or bring the forehead and midface forward. And for better or worse, there can be a fair amount of subjective artistry without computer-assisted planning in the mix. So CAP is basically used across multiple industries to facilitate accuracy, precision, and further the advancement of technology. But really looking at it sort of from a business perspective, you want it to do something. You want it to impact an improvement in communication, productivity, quality, or data, provide you with more information. And I think these are pretty reasonable evaluative tools for the technology, and we'll look at its impact on each of these. So this is a patient who's about 45. In her infancy, she was treated for unicorodal craniosynostosis with a strip craniectomy. She went on to refuse, and because she lived on the other side of the mountain, no further treatment was undertaken. She's totally neurocognitively functional, and she came to us to see if there was anything that could be done from a cosmetic perspective. In the last decade or so, there's been a big increase in computer-assisted design and manufacturing for craniosynostosis. And so we'll review some of the literature and then come back to this patient and see how it might have helped her. So most of our CAP in craniofacial world is done through virtual surgical planning. So this is Dr. Alexander, one of my neurosurgeons, a screenshot of her and I on a call. We get a high resolution CAT scan, convert it to DICOM. Come online, you can do this on your phone. Computers are better, so you can see a little better. there's an engineer, and we can either use normative comparisons, mirror imaging of the patient, or our own imagination, basically. And you can design the bony cuts, how you want to modulate it, the vectors of distraction, and the type of movements that you want to undertake with the skull and the facial bones. And then you can design cutting and shaping guides, which they'll 3D print and send to you in a sterile fashion. These are a number of really powerful articles supporting when and how to use this technology. It helps us to recognize that traditional techniques can result in inconsistent results due to the challenges basically with analysis, teaching, technique, and the learning curve that comes with some of these complex procedures. They give us recommendations, providing guidance for approaches and tools in medical 3D printing, from how to do the image acquisition, segmentation from the desired anatomy intended for 3D printing. And now we're going to look at how CAP can impact some of the tools we're using to measure these outcomes. So how does it impact communication? You want it to either improve communication between you and the patient, or you and your colleagues, or to relay educational perspectives. So this is me in my fellowship with a 3D printed model of a young girl with craniofacial nasal dysplasia. And that's my fellowship director the weekend before teaching me how to make the cuts, right? It's very hard to educate on the fly, high stakes, and therefore participating in these virtual surgical plans and practicing with simulation-based models can be really beneficial. Here's one of our residents undertaking the cuts for a very similar case here at Children's Hospital. So lots of groups have highlighted the importance of 3D printed models for surgical simulation. It gives you tactile feedback, and hopefully it's a very accurate reproduction of the nuances of craniofacial surgery compared to, say, like an animal or cadaveric model, which really can't mimic the elevated bones or the abnormal bones in a particular craniofacial condition. And also the thickness in pediatric bones is very different. And they can be high cost. These are models that haunt my desk, but we do this quite a bit over at the Children's Hospital. So how does it improve clarity and innovation? This is a kiddo early in my career. He had a Kleeblatt-Shadel skull or cloverleaf skull. All of his sutures are fused. Very, very typical head shape. The brain is being squeezed. How are we going to improve his outcome? Well, I learned about posterior distraction in fellowship, and so I said, okay, we're going to do this. We'll make these bony cuts. We'll put distractors on, and we'll, take his skull back and make this more. And my neurosurgeon came in and said, why don't we make it two pieces? I said, what? I hadn't thought of that, because he has sort of the buckle of the two portions of his skull. So we did a differential distraction, brought the inferior portion back as far as we wanted, and then kept going with the superior part. Kiddo had crazy antennas sticking out of his head for about 2 months, come back, take him out. And he gets a much more rounded head shape than we would have had I not had this computer assisted and 3D printed design to communicate with my neurosurgeon. Patients and family and communication has improved. This is a kiddo who had bicoronal craniosynostosis, so both sutures in the front were closed. And despite having the surgery, he still had a very sloped forehead. And he also had a skull defect, but we spoke with the family and included them in the virtual surgical plan and said, not only do we need to patch that hole, but we have an opportunity to put an onlay graft made of Medpor, 3D printed, to improve your forehead shape. Would you like to see this simulation? And the patient and the family got to participate in the planning and ultimate better outcome for both a functional and cosmetic result. So it helps with communication. Can it help with productivity? Well, productivity is typically thought of the profit that's brought in, and in surgery that translates to potentially increasing speed and efficiency of surgery, the cost, and we have to factor in the cost of the technology, and downstream impacts the need for repeat surgery. So craniofacial surgery does require 3D and temporal perspectives, meaning you're operating on a moving target because the child is sitting down. And so you have to factor in the child's continued growth, potential relapse, and then still aim for perfection. So some groups are looking at ideal templates. So this is what a forehead should look like. You sterilize this and you bend it appropriately when you're fixing, say, a trigonocephalic head shape. This is a modulatable, an adjustable template to model various bandos. And there's a small, medium, and large that came out of Sick Kids templates based on normative database. based on age. And all of these studies, improvement in outcome and decreased time in the OR. But it is somewhat of a mixed picture for cost. There are some demonstrations of time and material improvement of cost compared to conventional techniques, but some raise concern of accessibility, the need for radiation, and whether or not insurance actually covers all of these models and designs. This is a comparative case control study of non-virtually surgically planned versus virtually surgically planned open procedures, and showed that you decrease operative time by 44 minutes in single suture and by 100 minutes in multi-sutural. And it also demonstrated a trend towards decreased operative time over the course of this VSP study period, implying a learning curve. Also, it can improve accuracy and efficiency. So this shows that there's dynamic programming algorithms comparing abnormal and ideal skull shapes, and basically use artificial intelligence to decide what the osteotomy should be and calculate the objective difference in surface area remaining between the normative and the dysmorphic skulls. So computer-assisted design can almost automate your planning and evaluate your outcome.
Hey, Brooke,
Yeah.
you adjust your microphone a little bit, get close to it. Is it in your earpiece, the microphone?
Yeah. Yeah.
Maybe move it around a little bit into a different spot, because
Is this any improvement?
yeah, or speak louder.
Okay.
Maybe too.
Okay, sorry about that.
Thank you.
Thank you. All right, so productivity and quality have some overlap in terms of value contribution. Is that an improvement in the sound? Okay.
That's better.
Great. We've looked at sort of faster and cheaper, but we need to this is improving the quality of our patients' outcomes like safety, blood loss, anesthetic duration, decreased need for future surgeries. So there's several studies looking at CAD/CAM technology to design cutting guides to accurately locate and avoid the superior sagittal sinus or the transverse sinuses. And in this study, no tears were encountered. It increased the surgeon's confidence, efficiency intraoperatively, and that can justify the prep time and work. And we do the same when we're doing posterior distractions here to avoid the transverse sinus. This is the example of a cutting guide. You use a pencil to draw, and then you cut where you intend, as well as with craniofacial dysplasias to avoid the superior sagittal sinus. We can improve our efficiency as well. This is a kiddo who had surgery for craniosynostosis as a child, but then went on to refuse his sutures. And he had elevated ICP, so we needed to expand his skull. So through a virtual surgical planning system, we could design the vectors, look for interferences, and also be able not only to get the cutting guides, but to get a legend that tells us how deep or how big the screws need to be and how thick the bone is and where exactly to put the plates. So it takes a lot of the intraoperative planning away when you already have this planned before. And you can see that he had an expanded skull and improvement on neurocognitive function. Several studies here looking at different impacts. The first one says, using a template versus no template, evaluating CAT scan and comparing the area under the curve shows that you basically get a better outcome afterwards if you do use virtual surgical planning. The second one is looking at a Johns Hopkins study, primary outcome of Whitaker scores, which is somewhat of a subjective, this looks good, we're not going to have to operate it on it again, but basically fewer revisions afterwards. And this helped less experienced plastic surgeons achieve better long-term results. It looked as good as more experienced plastic surgeons. And finally, a review of 13 patients who underwent complex craniofacial procedures with the aid of computer-assisted design showed accuracy improvements and decreased operative time. So back to our patient. She elected for an on-leg cranioplasty, sort of like placing an awning over that orbit on the right that doesn't have as much hooding over it or photobossing, and ultimately had a very reasonable result. You can see her implant, and she subsequently had an asymmetric blepharoplasty to make her eyelids look more symmetric, as well as fat grafting to feather the appearance. But overall had a very nice result that she couldn't have had when she was an infant. So lots of future information databases, machine learning, artificial intelligence, etc. And the exciting thing is, or the question really is it a technical imperative? Because there are some negative potential impacts like time, radiation, cost. You don't want it to be like an automated car, an app behind the wheel, right? Still use your surgical expertise in your brain to protect and strive for these patients. So it's basically thought of as a technology to be used in a really innovative way in craniofacial surgery. It doesn't replace your surgical skill or judgment, but it can be thought of as a tool to enhance our shared experience of craniofacial differences. So I gave a version of this talk about a year ago, and then of course COVID struck, which gives the gift and time to pause and sort of reflect on how best to integrate some of these tools into outcomes for patients with craniofacial differences, and potentially to help our trainees as well, because that's part of our mission here at CU. So we started the fetal stages of developing an innovative platform for surgical training models. In particular, thinking about this population of kids with cleft lip and palate. So they get their lips repaired in infancy, their palates repaired in infancy, and then they can have 5 to 10 more surgical procedures to repair this. And I want to start thinking about how to integrate computer-assisted technologies to get better outcomes for these patients. So more complicated they are, more complicated the surgeries are. And it is very clear that surgical training and expertise are correlated with better outcomes in cleft care. So if fewer reoperation rates, improved speech outcomes, and better successes. So current surgical training models, especially in cleft and craniofacial, is the usual C1, D1. However, there's a lot of evidence that proficiency-based progression, which is training programs that dictate that the skill performance is demonstrated prior to being able to advance to the more complex techniques that give you benchmarks. And there's lots of evidence that basically simulation with assessment of proficiency results in superior training. So enter virtual reality, right? There's maybe 10 different platforms that include surgical training, most of which are orthopedic or neurosurgical. OSO VR is probably the most advanced and also the most commercially available. And there's already evidence that virtual reality used in plastic surgery, specifically temporal bone surgery, rhomboid skin flaps, cleft lip, is advantageous and can help. So again, this 3D printing has also been proven objectively to improve learners' acquisition of technical knowledge and milestones. Oh, and another thing, we don't really measure resident proficiency super great. It's case minimums, retrospective reviews, and maybe isn't the very best way of surgical skill acquisition. So back to the cleft patient. So in particular, a surgery called alveolar bone grafting, which is done usually when the child's about 7 or 8 years of age, when their dentoskeletal development is really particular. They're about to hatch their permanent teeth. Well, we need to go in then and put bone there so that they have space to grow, and then you can put kids in braces, and then they have a much better functional and aesthetic outcome. So it's a relatively complex surgery, and it's very difficult to teach. You're basically operating in an ice cream cone. Often the resident is down at the hip harvesting the iliac crest bone graft, and so they can't see very much. And to be completely honest, I didn't do a whole one all by myself until I was out in practice. And primary failures and revisions result in extra surgery. And right now there's an absence of an effective low stakes and high fidelity training model to practice and then assess for the proficiency in the case of the ABG. It requires fine maneuvering in a small space with a range of soft and hard tissues, including oral and nasal mucosa, bone, teeth, nerves, and hard palate. And it's really challenging to teach without potential harm to the patient. So the gap is that the current VR platforms don't really support fine motor training controllers for surgeries like ABG, like they're ortho, so they have to hammer and break bones. And 3D printed models currently are unable to really accurately capture the density heterogeneity required to simulate the various tissues associated with this intervention. And I mean by that most 3D printed things, while very cool and proven to help, don't really capture like mucosa and muscle and nerves and the tension across these. So what we proposed to do was to create an integrated platform, both VR and 3D. And we want to basically mix the modalities of VR and 3D simulation and prepare surgeons training. So what needs to happen is we have to film the procedures to get the program module going, define proficiency and errors, and develop teaching modules with program platforms. Secondly, we need better mechanical development, either with gloves, with haptics, or instruments. And then finally, we're going to build upon OSOVR's assessment tools. Built into OSOVR, efficiency of motion, speed evaluations, and basically can tell you extraordinary levels of feedback of how close you're getting to being proficient and where you need to focus your efforts. So this is an image showing this sort of novel voxel 3D printed technology that Nick Jacobson, who works at InWorks, he's an architect and a computational designer, many of you must know him, used basically DICOM models to remap the Hounsfield units to like alternative colors and differential densitometries in the printed form. And so this is us trying to make a alveolar bone graft model where you have mucosa and bone and teeth that really feel like it. Images of what he's done with cardiac and neurosurgeons and the orthopedic surgeons. He's really quite gifted and makes beautiful models. And then we'll basically prospectively evaluate the impact of virtual reality and 3D on the proficiency of the surgeon being trained. Those models basically helps you get repetitive guided practice without harm, enhance the procedural skills of surgeons while providing data on how much practice is really necessary to get proficient through these strong assessments. And then, of course, the goal is to improve surgical outcomes and quality of life for cleft patients. Ultimately, what we're planning to do, of course, is accelerate and improve surgical training, design approach, enabling extension across surgical specialties. So there's a number of collaborators, of course, across radiology, anesthesiology, pulmonology, school of public health, orthopedics, to have a space allocation and supported children for a VR theater and a 3D printed theater where we can really grow this, not only this tiny little thing that we're working on, but all of the things that are interrelated to it. And with that, I think everybody has helped that are very obvious, and there are so many more that have helped along the way that I don't have listed here too. But look forward to anybody who'd like to collaborate with us on this. Thank you.
Thank you, Dr. French. That was a great talk. I've got actually a couple of questions. So with your VR, I mean, what's the actual interface? Is that something that you're designing de novo, or are you going to take over like a Game Boy type 3D virtual reality machine, or is there some other platform you're going to use?
When we started this about a year ago, we started from the bottom, and we were going to get our own designers, and we were going to try to get under the hood of an existing platform. And we were seeking NIH funding, and then we realized, why are we starting at ground zero? And then we went directly to the source. And OSOVR's CEO is actually an orthopedic surgeon who's a wonderful human and collaborator. And we're now getting industry funding to work together. So it's going to be under OSOVR with their programmers. They have Pixar, Oscar-winning VR designers and artists. So it's a collaboration.
And then, what machine do they do this in? I mean, so...
Oh yeah. I mean, it's actually a commercially available virtual reality headset. So you put it on, and it comes with laptops and screens. We intend to have a little theater with 12 to 20 stations that you can take apart, and have a training theater in the front where you can, and it comes with its own computer that measures all these assessment outcomes, your surgical skills. And
then do you wear gloves? Does it follow your hands too, or?
It doesn't right now. The goal is actually to get an adaptable iPad pen with different instruments based in it, and assign it to each type of surgery, across plastic surgery, across urology, etc.
But how would you like dissect with it though? I mean, you can see the 3D structures, but how would you actually start pulling those tissues apart, or incising, or cauterizing, or whatever you do?
The goal is to use that pencil, or much like an instrument, and then the artist translates that into surgical feedback.
Got it. Yeah.
The glove concept, while it sounds really, really, really cool, has been tried multiple times, and it's hard because they don't fit everybody. and the haptic feedback that everyone thinks is really hasn't always proven to be quite as helpful. So John Radin actually came up with the idea for the pen.
Yeah, and I'm wondering, I mean, is there a way to not use the robot per se, but I mean, there's a lot of technology in the robot, and they already have things that follow your fingers, and they already have the three-dimensional. So I wonder if there's a way to point this towards the robot and take advantage of all the things the robot already has. And yes, it may not be equivalent to open incision surgery, but I bet you there are a lot of things that you could capitalize on in using the technology already in the robot.
That's a very good point. Yeah, I like that.
Yeah. All right. And any other questions out there? Okay. Oh, actually, there's a comment from Jonathan Radin. So, obviously, you've been working on this since I've arrived here, which is 9 years ago. And you've been a trailblazer, and that's both good and it's bad. I mean, you've had to find ways of doing things and try to find, who to work with and what the resources are. Do you have any advice for anyone else in the Department of Surgery or anywhere in terms of efficient steps for engaging in projects like this?
Thank you. To me, true. It is a challenge, and it depends on what perspective you look at. It's wonderful that I've had the opportunity to work on this for almost 10 years. It's also a little humbling that it's taken this long to get things incrementally further along. And there are a multitude of groups on campus who each are trying to. And the good news is that they're all extremely collaborative and very happy to work with each other. So just like Jonathan's note in the chat says, email him, email me. Everybody wants to work together. This space allocation that we're looking for at Children's is not just for us. It's for anesthesia who has VR to control pain, and it's for cardiology who's trying to actually print things at our institution to use in their surgeries, etc. So we're all here. CU Innovations is also very good at getting people connected.
Great. So I guess Jonathan Radin is a resource, and I would point all members of the Department of Surgery who want to tackle big, innovative projects like this to at least touch bases with him to find out what the resources are. So Dr. French, Brooke, thank you so much for this excellent talk. I heard an iteration of this maybe about 5 years ago, and you have come a long way. So thank you so much.
Thank you very much.
All right, bye. All right, everyone, have a great day.